What is plasma? So I'm not a physicist, but it's a fourth state of matter. So we have solid, liquid, gas, and plasma. And if you put a lot of energy into a gas, some of the electrons can leave the atoms, and that creates a plasma. It's what's found in the sun and in the stars. Supposedly the vast amount of matter, the majority of matter in the universe is made of plasma. What about plasma TRP? Well, the beauty of it for me is it's just the standard TRP. So the technique is exactly the same. You're pulling a loop through tissue to resect it. But the difference is the active and the return electrode are contained within the resectoscope. The high frequency current creates this plasma corona on the end of the loop, and when that's ignited, you can get cutting or vaporization. It uses saline for irrigation, so you haven't got the risk of a TUR syndrome that you have with glycine. And because of the way the system works, essentially there's very little bleeding with the operation. So you can operate for longer, particularly with the saline, and as I think we'll demonstrate, you can certainly do it as a day case. And there's a number of instruments that you can attach to the system, but these are the two that I use. So a loop for cutting and cautery. And in fact, I actually seal the vessels with the loop as well in the majority of cases. One other advantage of the loop, a little point of technique, is that it's self-cleaning. So if you've got tissue stuck to the end of the loop, you don't have to take it out and clean it. You can just press the cutting pedal and it will ablate it away and clean the loop for you. NICE have looked at this technology. They looked at it a few years ago and they came to these conclusions, essentially. TURist system, as it was called then, or plasma TUR, avoids the risk of TUR syndrome because of the saline, less bleeding, may reduce the length of stay, easily introduced with minimal training, as I've mentioned, and can save money, as I'll come to. Now, we, as you all have problems with short notice hospital cancellations because of a lack of beds, and I'll highlight the figure. I haven't got a pointer, but the total by hospital, all short-term notice cancellations of 1,711. So this is for a 12-month period in my hospital. I just got my manager to look this up for me. How many cancellations did we have last year? That's a big figure, essentially. And it's not just us down in Worthing that has this problem. It's a national problem. This is from an article in the Daily Telegraph, May this year. 25,000 operations in the first quarter of this year cancelled. Highest in almost 25 years, and we all know it's because there's no beds. They're all full of elderly care patients, generally, certainly with us, who are stuck, and for a want of social care, bed pressures, we can't get them moved on into the community. And if a case is to be blocked on the day, if it's to be cancelled, then more often than not, it's going to be the elective TURP that gets cancelled. So because of this, we asked this question a few years ago: could we do day case prostatectomy using plasma TRP to free up valuable beds? In that period, before we started doing it, April 2013 to March 2014, we did 128 monopolar TURPs, but only 2 were day case. Average length of stay was 2.5 days. Many patients failed their inpatient. We had a real problem with patients failing their inpatient TOC and having to come back for a TOC later, so we weren't doing well, essentially. So this is the question we asked: could we do it as a day case, essentially? And to start off with, we looked around to see if we could learn from others. We weren't new to the game. We went to Portsmouth, nearby. Stuart Hall's doing it, and he was managing a 50% day case rate. Is TURist going to be more expensive? So we did a business case, and it's based on this, that there's a best practice tariff of £213 per case if you do your TURP as a day case. And this gives you a significant uplift, and on the basis of this you can do a detailed income and expenditure analysis. I won't dwell on this in great detail, but essentially you can look at all the costs of standard TURP against plasma TURP. We modelled different day case rates. I'm showing here 80% and 70% day case rates, and we looked at the additional cost of the plasma TUR in the different situations. And essentially, you can save these large amounts of money. We also modelled in using the button in 15% of the cases, that sort of thing. So we went into detail on this, and as I say, I don't want to dwell on it too much, but essentially, you can save at least around £6,000 a year in a small DGH like ours. What about saving beds? Well, across our whole trust, so we're 2 hospitals. We perform about 285 TORs in a year. So if we moved those 75% as a day case, we can save 582 beds, well, 514 beds, and that's equivalent to 1.4 permanent beds. And if you look at the cost savings of this, that equates to this figure, £122,000. It's a little bit more complicated than that, because if you don't do a TURP as a day case, you don't necessarily save that money because the bed isn't closed. So they're notional savings, but nonetheless, true savings are estimated in terms of moving to day case at around this figure of around £100,000. So it's impressive savings for your trust. So what about my own personal experience? This is my hospital that I work in, or one of the hospitals that I work in. It's called Southlands Hospital. It's towards Brighton. It's away from my main hospital in Worthing. We have a day case unit there, and we do outpatients as well. It's a standalone unit in that there aren't any inpatient beds. So at the end of the day surgery unit closes and everyone goes home. There's no ward. And if we operate on them, they need to be admitted, they have to make this journey across town to the main hospital. It's shown here at about 14 minutes, but in rush hour it takes a lot longer than that. So it's very inconvenient to put someone in an ambulance with a nurse, with irrigation running, and move them across to the other hospital. So we asked this question, could we deliver the TURP in this unit with no beds? So I did a prospective audit of my own cases when I started. To make the maths easy, 100 cases, we didn't have to work out the percentages. There's no exclusions, includes the learning curve, and these are consecutive cases. We did a talk on day 5 because I tend to operate on a Thursday and we didn't want to remove the catheter at the weekend, but the patients went home with a catheter. The median age was 70, 11 patients were 80 and over. Half of the patients were in retention, and of those, most of them had a catheter at the time of surgery. So we had a lot of patients with a catheter in retention. Okay. These were the prostate volumes. Now, we did have an intention that over 80 cc's, we wouldn't put them through the daycare unit, but in fact, only 63 of the patients had measured prostate volumes, and 13 were above 80 cc's. Average resection time, 38 minutes, volume 17 grams, and I managed to just use the button diathermy electrode in 11 cases, so about 1 in 10. Now, how do we get on? Only one patient of the 100 needed to have that ambulance transfer to the main hospital due to hematuria, and he was discharged after overnight observation. Okay? And within the first 30 days, 4 other patients were readmitted, 1 with sepsis, 1 with acute retention, and 2 with hematuria. We had no perioperative blood transfusions, with only 1 patient needed a transfusion at day 13 because of a secondary hemorrhage. So during the same period, 18 people went to A&E. Now, you probably wouldn't know that this was happening unless you audited it, but they were all discharged within 4 hours, so they weren't admitted, and 12 were with blocked catheters requiring flushing, 1 with a catheter-related penile pain, 1 was worried about hematuria, rosé hematuria, 1 requested a TWOC after the TWOC clinic was cancelled, and 2 had retention after a TWOC, and 1 had LUTS. So this perhaps illustrates that when we first set up the service, we didn't really have robust enough follow-up for these patients, and many of them came up to A&E just for reassurance, and we've introduced a policy of next-day follow-up, telephone follow-up, and given patients open access to our outpatient clinics, and we've seen a dramatic drop in them attending A&E. With regard to the catheterization rates, 41 patients, as I said, had a catheter in situ preoperatively, and average time to TWOC was 5.8 days, because of the weekend mainly. 95% or 95 patients passed their first TWOC with 99 catheter-free at 30 days. Patient satisfaction rates, there's a complicated slide here that you could look on Ola's posted tomorrow, but essentially we had good satisfaction rates. And then finally, looking at the big picture, across the 2 sites, how many did I manage to do as day case? So I did 174 TURPs in total over these 3 years. So 57 and a half were done in the standalone unit, but overall, because we discharged some cases from the main hospital, my day case rate was 65% essentially. But in the standalone unit, as I said, 99%. So just in summary, really, I think based on this 3-year experience, we've demonstrated that day case prostate surgery, plasma prostate surgery is feasible, safe, it's effective. We've got a very high discharge rate, low rates of readmission. We had no TOR syndromes and no perioperative transfusion. And I'd put it to you that it's, I think if I can do it, or we can do it in a standalone unit with no beds, then most urologists could deliver this in their normal DSU, normal day surgery unit, attached to their normal hospital. Thank you very much.